Hello, everyone. I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University. And today happens to be um, Doctor's Day. So, for Doctor's Day, I wanted to go over some of my experiences when I was going through training in medicine. And there's a lot of different components to consider when you're seeing a patient, and things that I've learned over the years of going in the medical practice. Now, for me, what happened was I trained in pre-med in college, and then I went into medical school, and then after a while, transitioned to another medical school. And completed my degree. So the first 2 years I completed in one place, and then the last 2 years in three cities: New York City, Maryland, Baltimore, Maryland, and then Atlanta, Georgia. So let's go ahead and get started. Let's take a look. What I was doing is kind of putting together some of the memories that I had of being in medical school and learning some of the facts to not only buttress my understanding of epidemiology, but also kind of giving you a flavor of how medicine is to this day. Of course, my training took place about 20 years ago, but some of these are still relevant in today's society as well. So one of the earliest memories of internal medicine was that patients were not there on time due to not even there at all, due to difficulties in transportation in Baltimore. And what happened was a lot of times there were no shows to the appointments, and this was discouraging, not only because the doctor doesn't get to see the patient, but also I didn't get to complete my hours as I wanted them to be completed. But it was important and interesting because this was the scene that transitioned me from medicine to epidemiology, public health, because I realized that I couldn't, as a medical doctor, I couldn't do as much as I could at being in public health and epidemiology, doing studies in that field. And I appreciate and I enjoy what I do, combining my knowledge of medicine and public health and being the ideal teacher for my students. So, of course, there were social factors that prevented patients from making their appointment, and not only that, when I was in medicine, a lot of times the glucose control wasn't there for diabetes. And there are many reasons. Of course, as you know, diabetes supplies can cost a lot of money, and also time to get to the places that are needed to get treated. So test strips, glucose monitor, all of these you require very good organization skills, and a lot of times that wasn't present or possible. So I really got to understand the underserved population, and that's one of the reasons that social determinants of health is something that I really have experienced through other patients as well. I remember, and one of the things that I remember, and this was tragic in Staten Island, and in a place called Rumsey. And there were ICU patients there with huge bed sores, and a lot of times because it's important for patients to be rotating all throughout the day and throughout multiple days. But unfortunately, even because of the frequency of having bed sores, tilting the patient, um, all across the spine, there were bed sores and there were tons of infections, and that was tragic to take a look at. So that was one of my other early memories, which made me think that public health might be a good option because there were understanding the upstream factors that was causing these medical conditions is especially important. So there was difficulty in lifting patients, of course, like I said, and due to heavy set individuals that were higher in weight. The other thing that I really observed early on, of course, this was in New York City, in Staten Island, is that it was very difficult weaning off patients off the vent machine. Of course, everybody knows about the curves that it takes a look at all of the different spirometry and all the different breathing patterns. But what the problem is when you're on a ventilation machine, it's very much forced breathing. So once you're accustomed to forced breathing, it's very difficult to have the patient breathe on their own. Takes some time to vent, sometimes a lot of time to wean them off. And of course, in psychiatry, I had a lot of different experiences in psychiatry. There were a lot of delusions there, and unfortunately, people that had lost touch with reality. And so, this woman, I was taking their history and kind of trying to understand in the history what was going on. And this woman, she was not pregnant, and she couldn't have babies, and she had the delusion that she was pregnant with over 30 babies. And so that's another thing that really hit home, is that there's so many medications that are thrown at them, and so you lose track of the patient, because you have to kind of, sometimes when the delusions get worse, you have to go back and start on another regimen of medications and build back up. And that's something that was, I hadn't read in any medical books, but made sense out of protocol. That's all we had. So of course, in Atlanta, when I went there, I worked at an urgent care, and of course, that was kind of like a sliding scale place, and a lot of the patients were Hispanic Americans, and so there, I had learned Spanish about taken about 4 years, and so we had to have kind of a cheat sheet about what medical Spanish looks like. And unfortunately, this was something difficult to remember, but it's like blood is sangre. And so this was something that was very important to know in medical Spanish. Um, so just like I told you, there are a lot of clinics, some clinics in Atlanta that catered to underserved population, just like that. And of course, I saw that in New York City as well, where there was one day in the week that medical doctors devoted to seeing patients that were underserved. And a lot of times hospitals had money set aside to accommodate patients that had no money or less money. The final thing, and this was kind of like taking a look at kind of the I would call it kind of a barbaric nature of doing surgery, and this is hip surgery. And when I assisted in a surgery where the hip was being replaced, sometimes it seemed like a little chisel sort of tool was being used to kind of replace the hip. That this kind of seemed to me barbaric, but I understood why this was done. And of course, at the beginning of the surgery, you had to make sure that all your you had to make sure that the Hibiclens was used, and you had to be sterile and things like that. And they checked how so there was sterile technique, and they checked twice or three times if that was the right hip to do, because a lot of times, sometimes patients had the surgery on the wrong side if they didn't check. So there's a lot of people in the surgery unit to be able to do that. Of course, vascular surgery is takes quite a few hours, and people that are able to do vascular surgery are very patient people. Sometimes it takes 7, 8 hours to conduct vascular surgery. So just to summarize, one of the things, or many of the scenarios that I've given you, happens to patients that are from the underserved minority population. And so understanding their plight, going upstream, understanding some of the social determinants that are that underlie all of these things is more important to understand rather than the condition, because when you're a medical doctor, you're treating one patient at a time. But when you're a public health official or an epidemiologist, you're treating thousands, if not millions, by having even having students or learning this. Saving millions one person at a time. And that's kind of the motto. When I went to Johns Hopkins for my master's degree in public health, this was the motto that was used. So that kind of sums up what takes place in the building of a medical doctor and a PhD in epidemiology. I hope this has made some sense. Thank you for listening.